The gateway to the West, Cardinal Nation. St. Louis, Missouri is home to some of the most brilliant doctors in the world. These doctors are pushing science to its limits, healing patients in new, innovative ways. And doing it at the same time, they're teaching the next generation of doctors how to save lives. Meet SLUCare radiologist Dr. Nadeem Parker, who has found a way for surgeons to virtually step inside a patient's body before going into the operating room. This is the science of healing.
So I have a friend who works in the gaming industry. He had seen the last Science of Healing show that showed our work about 3D printing. And he suggested to me, why don't I use virtual reality or augmented reality to help physicians and patients with the same thing that I do with 3D printing. And I went back and thought about that, and it seemed like a good idea.
This project got started when Dr. Nadeem Parker reached out to David Hawkinson, our CIO and Chief Innovation Officer. We've been showing off a lot of 3D and virtual reality tools to the campus, looking for ideas that might have potential impact to healthcare, and this sounded like a great fit for us.
We thought that we would be able to help the physicians look at organs that in 3 dimensions rather than just 2 dimensions. We as radiologists are very used to seeing things in 2 dimensions, and we construct a report for the physicians who then have to reconstruct that report into a 3-dimensional picture in their head. So we got together and we studied a lot about what was done in virtual reality and augmented reality. We spent a couple of months studying about the different ways in which we could do things and the different modalities that were available for us to convert CT and the MR images.
Our next step was to look and see if anybody was doing this already so we could leverage an existing technology. We weren't able to find any companies that were doing this sort of thing in the medical space, so we started researching potential partners to help us design a new application.
It was difficult at that time for me to determine whether I would get there or not, because I didn't have enough knowledge about how virtual reality would work with medical imaging and healthcare. But as I got to know more and more, it seemed that it was possible that we could do this.
It's always great to be the first, but it's also really great to have the opportunity to impact patient care in a positive way. So the technology works by taking CT scans, which are normally multi-layers of 2-dimensional scans, and it imports the scan into a volume viewer. So it basically takes all of the 2D images and renders a 3D image.
We started taking the CT scans and MRIs that we did for our referring physicians, where you could see it in different planes. You could insert yourself within the environment and look at different structures.
When you put on the virtual reality glasses, you can see the imaging data, but it's displayed in a manner that looks more like real life, hence, virtual reality. And so you can look at a liver or a human brain, and it looks much more like what the actual organ would look like in real life, rather than just looking at flat 2-dimensional images.
We then share this with the physicians who use these scans in 3-dimensional format to operate on these patients.
You really feel like you're there. You feel like you're there. The room that they have, their system set up in really looks like a Star Trek room, gray with, gray walls, and you feel like you're there. You can move around in the room.
It's an amazing experience. I did not think that I will ever experience something like that. It is very vivid. You can see the structures very well in a 3-dimensional way, and you feel actually that you are inside the organ itself, looking at the tumor and looking all the vessels and the liver tissue itself.
At first, you have to take a step back and realize that you're actually in virtual reality. But once you start kind of get used to using the tools, you can combine different types of images and really play with it in such a way that really allows your imagination to run wild. I mean, you could really replicate what goes on in the operating room and really what goes on as you dissect, which is the most difficult part with all of the other older technologies that we have.
And so far, everyone that we've had put on the glasses and look at the data has pretty much the same reaction. They're all blown away. You know, they're all very enthusiastic, excited about it, and they almost all use the word cool.
Dr. Parker had first set up for me a number of different models based on different types of images on pedestals. And with that two-dimensional square that he talked about. And when I picked up one of the brains, I could suspend it in midair and I started combining the different types of anatomy. At one point I decided I didn't want to look at one particular sequence, so I put it back down on the pedestal and it bounced. And in my rush to pick it up, I knocked over that pedestal, then the other one, and I really thought that I had to pick all of these things up and put them all back, and then I realized I was really in a virtual world, so it didn't matter.
Correct. The whole idea is to take a two-dimensional image and convert it into three-dimensional, because that's what you're going to see when you're operating.
The case in particular that we decided to apply this technology to was a 10-year-old girl who presented with a generalized tonic-clonic seizure. Her physical exam was normal after the seizure recovered, but her imaging was consistent with a brain tumor in a part of the brain called the insula.
And in the MRI, we mapped the vessels and the tracts in the brain. And then he came by and he looked at the imaging in a virtual reality format, so he could plan his surgery as to how he could approach the tumor.
Now, the insula is a very deep part of the brain, underneath the frontal and temporal lobes. Hers was on the right side. And the importance of the insula cannot be understated. It can be very devastating to basically just make your way to that tissue and remove the tumor. So as one of the surgical adjuncts we use was this type of virtual reality technology, allowing us to really be certain that we knew what corridors in the brain we were going to use and what we would see as we dissected through those natural corridors. And in the end, we used natural corridors that really only had us go through approximately 4 millimeters of brain. We removed the lesion in its entirety. She woke up perfectly normal, and the tumor was completely resected. So we were happy.
The transplant surgeons, Dr. Varma and Dr. Nazal, have given me a couple of cases which we planned for them prior to surgery. So liver transplants, renal transplants, those cases, any major liver surgeries that they perform, those kinds of cases have been done with the transplant surgeons.
This was a patient that had colon cancer with a large amount of metastasis to the liver, which is pretty common with colon cancer patients to have disease that can't travel to the liver. Unfortunately, this patient had a huge mass, more than what we usually see. And usually surgery in these patients can make them survive much longer than any other thing like chemotherapy or anything like that. And moreover, this patient did not respond well to chemotherapy. Her tumors were not shrinking with the chemotherapy. So it was critical to try to remove the tumor. Her tumor was next to a major vascular structure that is called the middle hepatic vein. This is the vein that we usually preserve, if we can, with the left side. So we were taking the right lobe of her liver, so we had to leave that vein with the left side. But the tumor was really close to that vein. The other vein that the tumor was close to was the left portal vein, which we have to keep with the left side of the liver for the patient to survive. So this technique, this new technology, helped me to try to roadmap what I'm going to do in the operating room. It helped me a lot to see where I'm going to go to try to avoid injuring the middle hepatic vein and the left portal vein. We have a 3-month scan on the patient. There's no tumor. Her liver numbers or function looks absolutely normal. She's still receiving chemotherapy. but overall, she did very well. She's very happy with the outcome. She's doing well overall. And I think, she definitely wanted to have a good outcome. She's like everyone that is going to go through an operation. She was very anxious. And I think this has helped her a lot with the surgery.
The physicians have been extremely happy with this because it is a new world and they get a complete view of what is going on. So their feedback has been very positive. We hope that it translates into better outcomes for their patients. And then we hope to share this with other patients and their families as well before they have their surgeries.
A huge part of neurosurgery is to be able to use a number of different types of tools to be able to get to deep parts of the brain without injuring anything else on the way in or out, to remove things like tumors, like blood vessel problems. We have to be able to get in and out without hurting anything else, and that's one of the hardest parts about neurosurgery. And this is just another tool to help us do that more effectively. In the virtual reality world, we're able to clearly visualize the blood vessels as they course from the surface of the brain to the depth. And we can use that kind of thing as a marker for our path and our path to the tumor and the margins of the tumor. This particular tumor and a lot of pediatric tumors are not that visually distinct from normal brain. Some people liken it to taking a pat of butter out of a block of margarine. It's really difficult to tell. Sometimes you have to rely on texture, color, but a lot of times you have to rely on anatomy, where the blood vessels are. You know that there's an artery at the superior aspect, anterior aspect of the tumor, and virtual reality really lets you get a sense of that before you actually get in there.
As a surgeon, we try to do a lot of preoperative planning. We try to be sure that we're not going to have any surprises in the operating room. We try to make sure that we have a plan before so that we don't start creating plans in the operating room, which most of the time usually affects the outcome. So if we can know what things to expect, patients usually do much better.
What I think these types of surgical adjuncts let you do is to gain a certain level of confidence that lets you move with more deft hands more quickly and let you make decisions with more confidence to know that, yes, I feel some slight tougher texture here. The blood vessel that I was suspicious was at the top of the tumor is there. This has to be tumor. So then I can take that out with confidence rather than with some degree of trepidation. Any confidence that you can get during surgery is helpful.
I think it gives the surgeon a very good plan before going to the operating room.
As we progress further, we can do is have multiple headsets that show the same thing. So the radiologist can wear one headset and the clinician, the surgeon, or the person doing the procedure can wear another headset, and patients or families of patients and medical students and residents can also wear another headset and see the same thing at the same time, and they can have a discussion about what they see and what the planned surgery or the planned procedure would be.
A lot of our patients, especially patients with liver tumors, they feel absolutely fine. They get a CAT scan because they have hepatitis, just what we call a screening image, and they have a tumor on their liver on imaging. Most of the time we have to show them the tumor on a CAT scan or an MRI to understand exactly what we're talking about. I think this kind of virtual reality where they see exactly where the tumor is, where their liver is, how their liver is looking like, I think that helps a lot the patient understand their disease and understand what we're gonna do exactly. I mean, these are operations that are very complex. So I think that helps a lot for them to understand exactly what we're gonna go and do.
It's very difficult for families to tell what's going on with their child when you point to a white ball in the middle of what they think is very foreign. So although we use three-dimensional models that are often store-bought, and posters and pictures of their own child's imagery, this can afford them at least a higher degree of understanding. And part of the goal with any type of surgery, whether it's for adults or children or spine or head or anything, is to have any patient understand what it is we're going to do and what it is that they're facing. And this technology potentially allows someone a view that will help them understand what it is that we're talking about.
I think once you have a better understanding of what is going on and what is going to be done, it will relieve a lot of the anxiety that you would have before undergoing the procedure. And I do think it might help in reducing complications as well.
What's interesting about the use of virtual reality in medicine is not just being able to use it at the back end and performing surgeries and things like that, or planning them. It's actually being able to teach.
You can learn in 3 dimensions and use simulation to learn various skills rather than learning on patients.
Looking at a picture in a book in 2 dimensions and trying to understand things is very different rather than looking at a 3-dimensional structure with an immersive environment.
I do a lot of spine surgery, so Dr. Parker had set up a CAT scan of the chest, abdomen, and pelvis, and I said, well, put that up. I want to see how I can manipulate that to actually describe the different approaches to the spine we use, because we can approach the spine anteriorly, laterally, and posteriorly, or any combination thereof. And what it allows you is sometimes very sly corridors to anatomy surgically that make the surgery minimally invasive to patients, but it sometimes is very hard to describe, and you have to go to the operating room and get your fingers in there to actually see how tissues fall apart, but how you can actually get those angles and trajectories, whereas in a virtual reality system it's very easy to describe.
It is difficult in the OR to have 5 people standing and looking at the procedure and being able to see what exactly is being done. Whereas when you have a virtual reality format, they will have a better understanding of what is going to be done in the OR.
As a medical student, I never imagined that I would be using these types of tools in order to prepare for surgery. I never thought I would.
In the future, it's going to be an integral part of telemedicine. So, for example, if you have cases in a rural hospital that have been scanned and they have a surgeon there, then you can create this environment and share it with them, with the surgeon being over there and the radiologist being at our institute. And you can show them what you have, where the pathology is. They can plan the approach and they can do the surgery.
Teleradiology is used all over the place. We use teleradiology in our own department to help cover some of the evening coverage at various different hospitals, and even during the day at times. So working virtual reality and augmented reality into that will probably just enhance our ability to provide great radiology services eventually.
For example, if there is a case, say 150 miles from here, they have done the scan, and they don't have the ability to do a particular procedure, and they want to know whether it can be done there or the patient needs to be sent here. A person here, like say Nazar or some other neurosurgeon, can wear a headset here, they can wear a headset there, and you should be able to see this because it's a digital age. You can get there.
So when a patient with liver cancer comes to our clinic, the major thing we'll look at is the imaging. And telemedicine can help with that. If we can see these patients that are 5-6 hours away, they can come over here several times. We can look at the images and while we're here, and then tell them our opinion about what we can do next. That might save them 3 or 4 trips to the hospital, and it'd be faster for them to get to see us rather than to wait.
One of the uses of virtual reality in telemedicine is to actually apply Western medical skills to problems in the third world where they don't actually have access to the same kind of training that we have, or they certainly, it's not a case where I can go help my partner down the street if they're trying something new. And as part of an international pediatric neurosurgery group, I've seen talks where people are trying telemedicine in 2 dimensions to help surgeons make decisions in live time in the operating room, where this would just offer that much more degree of certainty and assistance rather than just a 2-dimensional image.
We hope to share this with as many people as we could. I have a few colleagues in other universities that I've already talked to, and some of them have come by and we've shared with them. We hope to have some setup created for them so that they can use it and see the benefits of this. And then we'll go outside the country as well to as many places as we can share with. We started way back with plain radiographs, then came the CT scanners, then came the MR scanners, and then you start making them faster. You create 3-dimensional structures that you see on a monitor, so although they rotate on the monitor, they're still on a 2-dimensional monitor. Following that came 3D printing, and now this is virtual reality. Virtual reality is much faster than 3D printing. It has that advantage.
I think this is the future. I think maybe in a few years, this will replace the other modalities like CT scans and MRIs.
And you can have a trauma patient come into the ER and you see a liver laceration or a splenic laceration on the scanner. You just transfer those images into the virtual reality program, and then you have the trauma surgeon put on the headset and just look inside as to where the laceration is, and they can determine what approach they're going to take to operate before they go to the OR.
So both SLUCare and the university collaborated to actually make this project a reality, to purchase the equipment, the software, to be able to actually set this up in a room permanently as it deserves and needs.
The benefit of working in an academic medical center is that we get the opportunity to advance medicine and then share it with the next generation of providers, and in some cases the rest of the world.
Well, this is 2018, which is the 200th year anniversary of St. Louis University, and it's very exciting to be a part of this institution and to kind of draw on the rich history of the university. So in the medical field, for example, Dr. Doisy was a Nobel Prize winner who was involved in the discovery of vitamin K, and then the first heart-lung transplant was performed at St. Louis University Hospital. More recently, the cure for hepatitis C, which has had a tremendous beneficial effect throughout the world. Our hepatologists here were very involved in that research. And so we're just trying to carry forward that tradition and in our very small way add something to it and build on that for the future.
There are a couple of things that I feel would help in expanding virtual reality. One is exposure. So we should have the ability to share this with as many physicians, and once the physicians start experiencing this and they like it, then we should have the ability to share this with patients and their families. That I think will be very helpful in the growth of virtual reality in medicine. And then we can expand that, like I said, to training and to medical education of students. All of these things collectively, I think, will have an increased growth in healthcare. To be very honest, I never thought that this would become a reality. This was like, an idea that you get by looking at the gaming industry. Think about applying that to medicine. And once it started developing, it was very hard initially because we had to read up a lot. We have to collaborate a lot with the engineering side.
Dr. Parker is very innovative, and he constantly surprises me with his broad range of talents and skills, which pop up in all kinds of unexpected areas.
There's a lot of work getting to where you want to be. But I think we got there, and we just need to develop this more and more so that it becomes more advanced and is able to help more and more people.
There's a lot of concern actually in radiology nowadays that technology, even though we're a very technology-based specialty, there's fear that technology will take over our jobs eventually. So artificial intelligence, machine learning. But that's really the wrong way to approach it. We need to embrace technology and use it as a tool that allows us to do our jobs better. And virtual reality is a perfect example of that. It's a tool that we can use to enhance our ability to take great care of our patients and to teach our medical students and residents.
It is amazing. I think there's a lot of technology that's going to come that's going to help a lot of patients, especially in surgical specialties. The images are so vivid. You feel truly like you're inside the organ. And then you can move it and you can take cuts in it.
Just using this technology more and to help us realize how we can best use it, and then to parlay that into what's called augmented reality, where you use a system that allows you to see what's actually going on in the room in addition to some virtual aspect.
You can play with it in any way, just like as if you're in the operating room looking at the organ in front of you. Actually more, because you're almost inside it. You can get inside and you can see the relation of the tumor to the vasculature directly.
Oh, it's a very humbling feeling to be part of something that is new and something that's going to grow. And in this case, it would not have been possible with the support of a lot of my colleagues that I work with. And I told you, Michael Moritz was one of the initial guys that worked with me, the IT people, Kyle Collins and his team, and the other folks that we've worked with, and all the physicians who refer all the challenging cases and give us the opportunity to do this.
Radiology is a technology-driven specialty, and it's exciting to be on the cutting edge. And virtual reality and augmented reality represents the cutting edge of technology, and trying to understand how we can apply that to improve our ability to take great care of patients and to teach the next generation of medical students and residents is really exciting.
I do believe that this is a game changer, yes, and it will bring more and more people towards radiology as to what we can offer as an advanced form of imaging.
I have a feeling that virtual reality will be used in all kinds of medical fields in the not too distant future, probably within a couple of years.